Topic is infective endocarditis. It's a very important topic. There are a lot of MCQs in your exam, in the PG exam also, and there is a full question over the infective endocarditis. And clinical perspectives, there is an important topic. Sometimes patients come to you with even chest pain, maybe a history of the fever in previous weeks, but patient is ignoring that, and patient comes to you in a month with history of the fever and chest pain, malaise, fatigue. So all these symptoms may be a case of infective endocarditis. There may be a native valve or there may be a prosthetic valve. So in introduction, a serious and potentially life-threatening condition of infection of the inner lining of the heart, that is called as endocardium, typically involving the heart valve, whether it may be a native valve or prosthetic. Prosthetic valve have more chance to develop infective endocarditis rather than native valve. It occurs when bacteria or other microorganisms enter the bloodstream and attach to areas of the heart that are already damaged or have prosthetic devices. In the native valve, if there is a regurgitant lesion like MR, AR, aortic regurgitation, mitral regurgitation, they have a more chance to develop organization of a microorganism at the site of damage due to regurgitation valve and then develop endocarditis. Prosthetic valve and prosthetic device that have already foreign body. So these foreign body attract the neutrophils and then microorganism and then development of the endocarditis. Infection that leads to formation of infected masses of tissue that is called as vegetation. That is important to know, that is infection in the form of vegetation. Vegetation is composed of some platelets, some fibrin tissue and infective organism on the part of the heart that is damaged, or the heart valve or the prosthetic valve. What is the pathogenesis? Obviously there is a valve is abnormal, or there is a prosthetic valve or native valve damaged. Then there is a adherence to neutrophils at the damaged site, and that damaged site attract the neutrophil. Neutrophil releases some cytokines, and the cytokines attract the platelets and release the fibrin degradation products. And that fibrin degradation product, again there is a cascade mechanism of the complement system, and that aggregate the clotting system, and the clotting system causes thrombus formation at the site. So bacteria then adhere to this thrombi and proliferation, because they act as a media for proliferation of the bacterium, and then develop endocarditis. In the source, there may be some IV drug user, some dental procedure have done. Patient have a prosthetic valve, patient have a damaged heart valve or heart wall, have IV drug user, dental procedure, some skin infection already is there, open wound is there, or some surgical procedure. So bacteria get entered in the blood and then adhere to the thrombi. So two mechanisms goes side by side, how the bacteria enters and how they provide the media for the growth. Ultimately there is endocarditis. So that is why we say that if the patient is going to dental procedure, whether we don't know there is endocarditis, chances of endocarditis, so advised to give some antibiotic before some procedure. That is same in any surgical procedure also. And then there is a vegetation formation. Depending on onset, clinical feature, course of disease, underlying conditions and causative organism, these can be divided in types. So divided in, most commonly is we divide in acute and subacute. Acute, there is a clinical feature, there is a rapid, as the name suggests, there is a rapid onset. A symptom develops immediately, often over weeks only. So patient complains of the symptoms only 2-3 weeks. Fever is high grade. There is difference from the subacute endocarditis. There is a high grade fever. There is in the subacute endocarditis there is a low grade fever. Systematic toxicities like symptoms like chills, malaise, and fatigue. Heart failure due to valve damage and severe valvular insufficiency. Some patient may present with heart failure. So there is a chances of patient complaints shortness of breath, palpitation, edema, history of fever over 2-3 weeks, malaise, weakness, fatigueness. So you should think about the infective endocarditis, maybe acute form. So acute infective endocarditis have some chances of embolic phenomena. This is more common in acute infective endocarditis, that is known as septic embolization. That emboli may lodge into the brain, that is a more hazardous or life-threatening condition and can stroke. If this goes to the lungs, then there is a pulmonary embolism, or some other organ like liver and spleen, there is a chances of abscess. So whenever there is a patient of abscess, or there is a stroke, or there is a pulmonary embolism, always suspect infective endocarditis. Whether it may be acute or whether it may be subacute, but more chances in an acute endocarditis. It can be treatable but life-threatening. Septic shock due to overwhelming infection. There is a septic shock, murmur. That is important sign. When we auscultate these patients over the heart or the precordium, there is a new murmur or systolic murmur, or there is already, if there is a patient have a mitral regurgitation or the aortic regurgitation, then there is a new murmur, new ejection or early systolic murmur that have changed. कभी आती है, कभी नहीं आती है. So there is a peculiarity of infective endocarditis, changing murmur. Skin manifestation in acute, there may be splinter, hemorrhage, patechi, as general lesion, because there is a two mechanism occurs, because there is a infection, endocarditis, vegetation, embolization in the pulmonaries, peripheral circulation. So there is a splinter hemorrhage in the nails, patechi over the skin, Zenbase lesion over the pulp of the fingers. So these are the some characteristic of the infective endocarditis. Echo, if we see for the echo, this is a large vegetation. These are seen on the valve or the endocardium. They appear as an echogenic mass on the heart valve. Valvular damage, significant destruction of the heart valve. This is a rupture of the valve or the perforation. So vegetation, large vegetation in the form of mass over the endocardium or the attached to heart valve. Already damaged valve, there is chances of significant destruction in the form of perforation, perforated heart valve, or the rupture. Sometimes there is a abscess along with vegetation, which may be seen as a fluid collection. Endocardium involvement in the form of extensive affecting not only the valve but surrounding structures also. Now, second is a subacute infective endocarditis. In the subacute, as the name suggests, there is a month, more than 6 weeks. More than 6 weeks means subacute. It's a gradual onset, low grade fever, typically lower than acute. So 100 and 101 or 99, low grade fever, fatigue often mild to progress. In these days, patients have a complaint of weight loss. At the night time, there is a night sweat. Embolic phenomena is the same like acute infective endocarditis, but it is less common in the subacute, more common in acute, like stroke, pulmonary embolism, new or changing murmur. That is present like acute infective endocarditis, especially in patients with predisposing condition like rheumatic heart disease, and patient have a MR or AR or the prosthetic valve. These have a murmur, but these again we have along with this additional murmur is there, that is new murmur, and that new murmur is a changing murmur, not constant murmur. Echo is different from the acute endocarditis. There is a small vegetation, often less mobile. They will be seen on the valve, atrioventricular surface of the endocardium. Mild valvular dysfunction, there is a lesser chances of perforation or valvular rupture. It depends on the acute and subacute over the organism types, because acute is more common by the acute infective organism like Staphylococcus. There have more chances to the rapid propagation, rapid proliferation, and rapid destruction. So that's why there is a chances of more perforation and more rupture of the valve. So there is a mild valvular dysfunction only. Abscess is less, but there may be seen a small abscess in the subacute endocarditis. Endocardial changes also seen. So in acute and subacute in comparison, we see that there is acute onset, there is insidious or gradual onset in subacute. Virulence of organism is very important, because these acute infective endocarditis causing bacteria are the highly virulent. Like subacute have a low virulent. Source of infection is often evident in acute type of infective endocarditis rather than subacute. Lesions are more common in the vegetation. More fluid affected valve is rapidly destroyed. Abscess formation is there, and less destructive in the subacute form, and formation of vegetation. Embolic episode are the rare. Mycotic aneurysm is common. Valve regurgitations. Splenic and renal infarct may be seen rather than abscess, because there is a mild form of endocarditis, so there is a chances of vegetation, and in the subacute form, rather than direct spread of organism like embolization, there is a chances of autoimmune phenomena is more common in the subacute type. That causes obliteration of vessels in the long period, so there is a chances of infarct, permanent damage of the organ, like splenic infarct and renal infarct. Clinically, acute underlying infection, there is a complication of endocarditis usually at the time of presentation. Acute infective endocarditis usually present by the acute presentation of underlying infections, like if a patient has a staph, so there is a high grade fever, malaise, weight and tiredness, weakness, fatigue, rather than a subacute. Course is a fulminant course, so there is a more dangerous, and the death may be occur within a 6 weeks. While there is a subacute is a protected case, but there is over weeks, but there is a chances of other complication of endocarditis is like autoimmune mechanism complication is more common. Causative organism, acute staph aureus, Pseudomonas, sometimes Candida infection, Streptococcus pneumonia, Neisseria gonorrhoeae. All these they have a highly virulent organism. Staph, Pseudomonas. While there is a subacute, there is Streptococcus viridans. This is the most common. Usually ask in your MCQ. Most common bacteria is Streptococcus viridans. Then there is a Streptococcus familiaris, bovis, Enterococcus faecalis, Staphylococcus aureus rarely, Hack group. H. influenzae, Hack means H Haemophilus influenzae, A. Acinetobacter bacilli, Actinomycetes, C. Cardiobacterium, E. Echinella, Kingella. So all these Hack group may be present with the subacute endocarditis. These have a rare group, but we should advise for culture for these organisms also. Importance of blood culture. So these bacteria can be identified with the blood culture. So blood cultures are essential for confirming the diagnosis of infective endocarditis. Identifying the causative organism and antibiotic sensitivity allow for the targeted antibiotic therapy, which is important for improving the patient's outcome. How the blood culture sample is taken and how the advice for blood culture and important aspect of the blood culture in the infective endocarditis, because there is chances of other organism may infect the sample also. So it should be in a sterile conditions. Typically 3 sets of blood culture are recommended to be drawn from different sites over a 24 period. So 3 bottles of blood culture at different site of venipuncture. These maximize the chances of detection for the pathogens. That's why there is recommended for 3 bottles for the blood culture. The blood sample should be ideally be obtained before starting the antibiotic. Obviously, if you start the antibiotic, there is a chances of sterile sample will be seen. Each set consists of 2 bottles to increase the chances of detecting both aerobic and anaerobic at each site. Result comes in the positive form, support the diagnosis of infective endocarditis and help to identify the specific pathogens. The most common pathogens are the Streptococcus viridans, the native valve endocarditis, Staph aureus, usually in the IV drug user, and the prosthetic valve. Enterococcus is the third one, and coagulative negative Staphylococcus in the prosthetic again, and fungus usually immunocompromised like a diabetes, HIV, or cancer patient is the chances of fungal type of infective endocarditis. Negative blood cultures may be seen around 10 to 20% patient of infective endocarditis. This may be due to first there is a antibiotic is given already. Second, there is a fast growth of bacteria like Coxella burnetii, Bartonella species that have not detected by the routine blood culture. Fungal or other non-bacterial infections. Organisms that do not grow well in the standard or usual blood culture media like Hack group. So we have to advise to sample of blood culture separately for the Hack group also. So these may have chances of negative blood culture. So diagnosis is usually we use the diagnosis by modified Duke's criteria that have included clinical feature, echo findings, and blood culture. So major criteria, if positive blood culture, obviously there is a positive blood culture indicate that infection means there is a infective endocarditis. So positive blood cultures are included in major criteria typically associated with infective endocarditis. And second is persistent bacterium, 2 or more blood culture positive for a microorganism that is consistent with endocarditis. Or even Staph and Coxella burnetii, single blood culture is single positive is ideally acceptable. Then echo evidence of endocardial involvement. So positive echo, transthoracic or the transesophageal, there is a showing the vegetation. Sometimes vegetation cannot be seen by transthoracic. Usually we do the transthoracic echo, but some specific conditions like a patient have a vegetation on the back side. In these conditions, we have to advise the TEE, transesophageal echo. So it can be seen by the echo vegetation easily. Masses of infected material, abscess can be identified, or new valvular regurgitation, new heart murmur can be identified on the echo. So both echo and blood culture included in major criteria. Other than minor criteria, there is a predisposing heart conditions like patient have a history of rheumatic heart disease or congenital heart disease or intravenous drug abuser. So these conditions have ideal for the infective endocarditis. So these are considered as a point of minor criteria. Fever, low grade fever, vascular phenomena, whether autoimmune or the direct embolization, arterial emboli, they can cause a stroke or organ damage in the infarct, septic pulmonary infarct, emboli to the lungs leading to infarction. In the palm, there is a Janvey lesion or painless erythematic lesion on the palm or sole. Immunological phenomena in the form of glomerulonephritis, rheumatoid factor. So false positive RA factor can be seen in the infective endocarditis. That is very important. Sometimes patient comes here with a mild joint pain. Mild joint pain can be seen in that infective endocarditis also. We advise for the rheumatoid factor RA, and we think there is a RA is there, but false positive RA can be seen in the infective endocarditis. That is due to immunological cross-reactivity phenomena. Glomerulonephritis, these patients have hematuria, urine in blood in urine. So glomerulonephritis, hematuria, RA positive, rheumatoid factor, Roth spot in the eyes, oscular nodes over the nodules, for painful nodules on the fingers. So these four are the immunological cross-reactivity autoimmune mechanism: Roth spot, oscular nodes, rheumatoid fever, glomerulonephritis. So once there is a direct embolization, other is autoimmune mechanism. Both can be seen in the subacute endocarditis, while in the acute endocarditis there is only embolic. Positive blood culture that does not meet the major criteria, blood culture positive for organs that are consistent with the infective endo but not with typical pathogen like Hack group, also considered in the minor criteria. So definitive diagnosis require two major criteria, or one major or three minor criteria, or sometimes all the five minor criteria. Possible endocarditis requires one major and one minor, or the three all the minor criteria. If there is another explanation for the finding of the criteria is not met, then we exclude from infective endocarditis. So suspicion is more important. How will you treat? The treatment of infective endocarditis typically involve a combination of medical therapies in the form of antibiotics, and rarely there is a requirement of the surgical intervention also. So exact approach, causative organism should be identified and hit the organism by the antibiotic. Patient's clinical status should be keep in mind. If there is any complication, treat the complication, like a patient have a glomerulonephritis, or there is a renal infarct or a splenic infarct, or there is septic embolization in the brain or pulmonary embolism, or any other underlying heart condition like RSD, rheumatoid heart disease, or patient in heart failure. So treat these conditions along with antibiotics. Surgical intervention. If there is a valve damage, or there is a abscess formation, or there is an uncontrolled infection, so there may be requirement of the surgical intervention also. So this is all about the infective endocarditis.